that was really nice summary of everyday practice, and let's move on to see what is next. And in terms of where is the field going, I'm going to talk about what is happening right now for us to get better in management of our patients and what is about to happen within, let's say, next 6 to 12 months. Not really about the ideas, what we might be doing 5 or 10 years down the road, but just to get the perspective what is happening right now. And to answer also questions about what happened with what we were highlighting a year ago. For example, where are we with those drugs that like telomerase inhibitor or antifibrotics are at the moment when we spoke about them last year so much in terms of being promising. And I do have quite a few to cover in 20 minutes. That's why I pulled this one out to object to the pathologists who sit in a WHO classification committee who reduced the number of entities in MPN. I object strongly, and I hope Dr. Carlos Bues-Ramos will object to me as a pathologist here. If you did not notice, we lost mastocytosis and we lost myeloid lymphoid neoplasms as entities that are taken out. So we are getting better in identifying subgroups of MPN, and then somebody in some committee is taking them out and saying they are not MPN anymore. That's not fair. They're just better classified or identified subgroups of MPN to me. And so in what I'm going to talk now about, I'm going to touch on mastocytosis, new developments in new drugs, as well as on myeloid lymphoid neoplasms. So quite a few disease entities to cover, and there will be a few slides on each of these in a relatively rapid fashion. I will be highlighting on the slides what is of importance, and not every aspect of each slide would be important as much, and you will have those slides for your use later on. All right, so let's go a few slides on ET. This would be current treatment continuum. If maybe you agree with me, most of the patients that are diagnosed with the ET are usually in 60s and plus. There is, as we all know, a little bit bump in incidence in young females, but most of the people are assumed to be on a drug once they're diagnosed, 60 plus, history of thrombosis, and perhaps JAK2 mutation. And if they don't do very well on the first-line therapy, which is typically hydroxyurea in orange color in the middle, some are on interferon, depends who you ask, but not too many. This is the first line. Then there is a second line, a variety of possibilities. We talked about ET yesterday, and anaglide comes up, interferon if you were not on interferon as a first line, alkylating agents, busulfan in occasional patient, perhaps something else. Is there a room for more? In a purple color, ruxolitinib is being considered as a possibility for second line in the clinical studies. And if you ask clinicians where is a need for a new drug development in ET, they will tell you. Ask the doctor. These are the studies in Europe in the ET that have been, some of them published, and the results of the first one on this table, MAGIC study, were already published. But you see the ET populations here that were tested in those studies. These are high-risk ET patients resistant intolerant to hydrea in 2 out of the 3 studies. So the academicians or practicing doctors will identify for the company where is the need for new drug development, and it is in a second line. So right now, therefore, we have a study, official study for possible approval of ruxolitinib in ET in second line, which is a blinded study, randomized study between ruxolitinib and anaglide in hydroxyurea resistant or intolerant patients. You see on the left side, 60 patients each arm, and it will be 1-year study without any crossover. The patients that end the 1-year randomization and are not responding very well, the open label then is a possibility for those that are not on ruxolitinib. The study already have several centers throughout the United States open, about 11 out of many more planned, and we hope to have these 120 patients enrolled during next 6 to 9 months. Little bit more on this particular study. In upper part are inclusion criteria. This is important. It is not only about resistant or intolerant to hydroxyurea, but have some aspects of the disease abnormalities that would require correction. You see the platelet count over 650, makes sense, but also elevated white cells. These are inclusion criteria, high platelets and high white cells together, because we have talked yesterday quite a bit that in addition to common criteria for assessing thrombotic risk appears that white cells have significant contribution, and therefore the study is for a particular group of patients that are hydria resistant with risk factors that are based on platelets and the high white cells and of course symptoms. So the goal of the therapy is to improve the white cells, platelets, and the symptoms, and the two arms are being compared. Let's move on to PV. This is one slide how we manage the PV at the moment. We assess the thrombotic risk in upper table using two factors. Then we treat those patients based on that thrombotic risk. Of course, high-risk patients, but also some low-risk patients in specific situations. Really impossible to identify what is the frequent phlebotomy or severe disease-related symptoms or progressive leukocytosis. This was very eloquently described yesterday in a PV talk. High platelets are reason for treatment because of risk of bleeding. In the lower part of the slides, we have what we do for these patients in the tables. Options for first line, hydroxyurea or interferon, busulfan rarely, and the second line we have now ruxolitinib as a primary option, or hydria or interferon if not already used. Where do we stand? What can we do better here? What does it make sense? That's a tough one. There is no clinical study that I know of in PV apart from DMD2 inhibitor as exploratory study in the hydroxyurea resistant and intolerant patients, where ruxolitinib is already approved recently for this group of patients. Is it easy to really see where and how to develop new drug? That's a tough one because we do have a good drug. This is a ROPEG interferon. Remind you, I talked about this yesterday myself at a lunch symposium. For those who were not there, it's a new form of interferon. This is differently prepared, so it's a super long acting and it's given under the skin every 2 weeks, perhaps even once a month. It has been tested in Europe so far, and in Europe it was submitted a couple of weeks ago for possible approval in polycythemia vera. And this was based on this particular study that I also explored yesterday, just briefly. As you see, the title is PROUD PV study for patients with PV that are therapy naive or previously treated with hydroxyurea, but not more than 3 years and not resistant or intolerant. So kind of a frontline setting where people were randomized between the hydroxyurea or ROPEG interferon, and the goal was non-inferiority. After 12 months of therapy, that was shown and presented at ASH last year. Non-inferiority was achieved, and application was put in place in Europe for approval. Now in the United States, we have to see how to really develop this drug, and hopefully in one way or the other for superiority rather than non-inferiority in first, second, or third line. Not easy task, but very good drug. Let's move on to myelofibrosis. Another area of looking at myelofibrosis, apart from looking at the risk of dying, which IPSS or DIPSS or any other new risk stratification is about, it's about risk of dying and referring patients to transplant sooner rather than later. It is also possible to look at clinical needs based on what is the problem. And the first one on the list is anemia. Many drugs, but none approved. Anemia is a major problem. We just heard Dr. Odenik comment the anemia is still a problem in the light of Jakafi or ruxolitinib. Ruxolitinib is good for some aspects of the disease, but not all, and we need more and better drugs. Any ideas? Many ideas. This is an indefinite list. These are groups of drugs rather than particular drugs. S at the end of each. Novel JAK inhibitors. There are 2 of them still in the contention, NA018 and pacritinib. There are PI3 kinase inhibitors. You see there are classes here rather than particular drugs. Mirabegron is the drug. I'll tell you more about this a little bit later, but there are many studies with single agents within these classes, and I don't have a winner to talk about yet. A little bit later, and after 2 minutes, I'll tell you about the contenders that are showing promise or showed promise a year ago and where they are now. But as we talked yesterday about, one way of improving our ability to tackle myelofibrosis is to combine with ruxolitinib. And I could just simply copy that, at least from the last slide to this slide, and say everything and anything is being combined. And it is true. At ASH last year, there were about 7 different presentations on combinations. And the ASH meeting in 2015, there were 12 reports of combinations. We don't have a winning combination, but everything and anything is being combined. We are actually in a situation where we have a good drug for spleen and symptoms. Median duration of the benefit is about 3 years. It does extend life for about 3 years, but it doesn't work forever. I like that summary that was already put forward. We need to build on that and perhaps add a medication to ruxolitinib. But the question is in whom and how to test it and what should be the endpoint, because not every myelofibrosis patient is the same as was eloquently described before. I'll give you an example of what we are seeing. What we are seeing here as a problem. These are the 3 drugs. In different colors are experiences within 3 different clinical studies with 3 different investigational agents. The orange is panovinostat, histone deacetylase inhibitor, then LDA and BKM are the other investigational agents of different classes. If you look, If you look across the board, spleen response in the first line below the title, the good spleen responses, median spleen reduction was good. What is at the bottom is the list of side effects. Why these studies mostly fail is the side effects of the combination partner. You actually compromise the ability of ruxolitinib to deliver good benefit to the patients by providing additional factor that is meant to improve that response and improve perhaps the cytopenias and improve the bone marrow function and enhance the spleen and liver and the symptomatic control from ruxolitinib. And yet what we are seeing across the board is that in most of the studies, combination partner is too toxic and then compromises even the delivery of ruxolitinib alone. So we may have occasional improvement of the overall response, but toxicity is the problem. Almost all the studies have the toxicity problem. Some had the lack of activity of the combination partner, like danazol, for example, but these are examples of what typically see. Combination factor is too toxic. And then how do we enhance on that? This was shown a year ago for those who were here. Something unusual, we don't see this often. Knowing the biology raises the possibility of combination of 3 medications. This comes from the work of Dr. Roslevin and Rajat Rampal, who is here, where 3 medications can be combined because it makes biological sense, targeting not just the JAK-STAT pathway, starting from the top, but also looking at the PIM kinase inhibitor in the middle and the oral inhibitor of CDK4 and 6 at the bottom. There is a further extension of this idea to laboratory results where the 3 together are much better than individual drugs, which is circled in red squares actually. It's in red squares. The results are much better with triple combination, and the triple combination is being tested in Europe. The single combinations or double combinations are being tested here in the United States, but the triple combination is being tested in patients with myelofibrosis as we speak in Europe. Bridging to transplantation, this is less and less of an investigational question. The investigational question is how to do it the best way, to expose the patient to JAK inhibitors to improve the body condition, decrease the spleen, and prepare patients over 2 or 3 months for the transplant when the transplant is a possibility. This is being investigated. In our own practice, that's a standard practice, but there is no consensus what dose, what schedule, and for how long, and when to stop the JAK inhibitor before the transplant. Our approach is for transplant candidates that have a donor to use high dose, 20 milligrams, 25 milligrams of ruxolitinib for 2 or 3 months to shrink the spleen as much as possible despite myelosuppression and get the patient with the smallest spleen, with the best body condition to a transplant 2 months later. Some are more cautious, starting with the lower dose and perhaps not treating patients all the way to the transplant. We treat patients to the day before the chemotherapy is given for the transplant, so there is no loss of response, which can be seen within 7 to 10 days, so there is no break. But this is being explored. This is where many studies around the globe are being done to optimize the delivery of ruxolitinib before the transplant. And so let's talk about individual drugs. This is a summary of two medications that have a similar mode of action. This is Sotatercept and Luspatercept, investigational agents. We heard in MDS talk about Luspatercept being something of promise for anemia. The phase 3 study is underway for possible approval in MDS. Sotatercept is similar medication. You see these are soluble receptors, fusion proteins that help engage erythropoiesis. And at last ASH, there was a summary of a small pilot study of Sotatercept in myelofibrosis with about 40% response rate. This is medication that is given under the skin every 3 weeks, outpatient setting every 3 weeks. And in this particular study, it's given in patients that were anemic, hemoglobin less than 10, transfusion dependent. If the hemoglobin goes above 11.5, then you don't give it anymore. You don't aim for 13, 14. So what I'm showing here is an example of one patient. These are hemoglobin measurements in blue. All these arrows are transfusions, right? The patient is transfused, go up, go down, go up and down every time patient gets transfusions. This is the first injection of the Sotatercept. Each of the red arrows are injections. The numbers go up. If they're above 11.5, no injection. And you wait for the drop and you inject as necessary. The study is accruing. This is an investigator-initiated study only at MD Anderson at the moment with about 30 patients so far. Update will be presented at ASH, but Luspatercept will be studied globally with the same hypothesis because of these results in several arms, even in patients on stable dose of ruxolitinib, but still anemic. So the patient that you described in your talk with anemia, splenomegaly, and bad quality of life, you use ruxolitinib for spleen and symptoms. For anemia, you may enroll patient on Luspatercept study that is coming through approval process in many centers around the United States. Telomerase inhibitor was big news. This is called the imetelstat more than a year ago because of results that were published in New England Journal of Medicine. This is just how it works. It inhibits the enzyme at the end of chromosomes that maintains the DNA integrity. If you inhibit it, the cells would lose the DNA and die off. This is the pilot study published by Dr. Teferi in New England Journal of Medicine, reporting 21% response rate in CR and PR, which is unheard of in any other situation with any other drug. We usually talk about clinical improvement, controlling signs and symptoms, not elimination of the disease. These are bone marrow examples of improvement. Unfortunately, not the good news. At the bottom in the right corner, a phase 2 study that was supposed to confirm these pilot results were halted. This is a 200-patient study, 2 arms, halted for further enrollment in November of last year, if I'm correct, because of lack of efficacy. We will see those results perhaps published at some point in time or reported, but that was announced by the company that took over the further development of imetelstat. So I'm sorry, but that does not appear to be a positive signal here. The other one that we talked about last year and earlier on in biology session yesterday was the PRM-151, which is the human pentraxin 2 injectable medication given under the skin as IV, once a month. It is all about the cartoon here. Monocytes are hypothesized to differentiate to fibrocytes, which are shown in 2 papers so far to actually contribute to fibrosis in myelofibrosis. So pentraxin is able to inhibit the differentiation of monocytes to fibrocytes, and then hypothesis is that if you decrease the fibrosis with this medication, you will restore hematopoiesis, as it's said here. Yesterday morning, Dr. Estrov showed some results on the mouse studies with this medication with ability in upper right corner B. This is survival of the mice with myelofibrosis with therapy with pentraxin 2, maintaining low-grade fibrosis or decreasing fibrosis, and the mice with progressive myelofibrosis dying off, not eliminating disease, but controlling fibrotic process and improving survival of mice. The study that is underway had 2 parts. there was 27 pilot study which showed these findings in the first 2 bullets. These were mild observations of some improvements in some patients with myelofibrosis that were transfusion requiring, having low platelets and spleen. So modest reduction in spleen and symptoms, some improvements in hemoglobin and platelets. And the larger study with 86 participants accrued all the patients by the November last year. This was in ruxolitinib resistant setting, and the results of this expanded 86 cohort will be possibly available by the end of this year or early next year. So we are kind of in a holding pattern to see what's going to happen with this drug. And there are some out-of-box ideas. I like that because we need something else new. Here we go, some basic biology findings that are relatively new, sometimes not that new. And this is about microenvironment and other factors that influence the growth of the cells. This is estrogen signaling and nestin-positive cells, neutral cells in the bone marrow environment that might have been mentioned before in biology section that appear to be important for survival of the malignant cells in the myelofibrotic bone marrow. And by stimulating nestin, which would be a medication called mirabegron, or blocking estrogen with tamoxifen, you would perhaps decrease the survival of the malignant clone and make them go away. You believe it or not, there are 2 studies actually doing that. This is another Cell paper that hypothesized and proved in a laboratory setting that you may, as you can see the title, affect the myeloid neoplasm by looking at estrogen signaling. And there is a study open in UK with tamoxifen to see whether this will actually happen to patients with the myelofibrosis. The other medication that I mentioned, this is mirabegron, was supposed to increase the nestin, and that's happened in the study that was only presented in poster. As you can see here, not going into the poster in detail, but the conclusion was, yes, it does what it's supposed to be doing, but it did not do anything about the disease itself. But it's very nice, interesting, out-of-the-box idea to improve possible bone marrow function and help patients. We need more of those rather than just going by the obvious intercellular signaling, for example. So what is next for myelofibrosis? That would be the obvious answer here. New treatment strategies with JAK inhibitors, novel medications, either novel JAK inhibitors that are still in contention. 2 of them are still, I would say, alive and being tested. Out of 11, only 2. Combination strategies, monotherapies. We should be improving our clinical decision-making much more based on the molecular profiling. We are making huge improvements in that regard. For patients with accelerated blastic phase, efforts are underway. We have had a nice summary on that. And then prevention of progression. It was mentioned earlier on that, in fact, that would be obviously the most important for the patients. And the study that was in Europe mentioned earlier yesterday for patients that have low-risk myelofibrosis and perhaps bad genetics would be randomized to placebo or ruxolitinib low dose as a first ever study to prevent progression in myelofibrosis. Unfortunately, that study just closed because of poor accrual. And unfortunately, disappointing for all of us. We're going to possibly try to entertain the same idea here in the United States very soon by the end of this year. Let's go to some unusual entities. Everybody knows about CNL, chronic neutrophilic leukemia, or atypical CML, just a few more diseases. Colony stimulating factor 3 receptor mutations were described in New England Journal of Medicine 4 years ago. They are usually in different parts of the membrane of the actual receptor. Some would signal through the JAK-STAT pathway. The other would go through. Finding the JAK1 here, right? JAK inhibitors, and here would be possibly inhibition of the SYK part of the possible signaling pathway. And therefore, further efforts were done by many since 2013 to see how often actually do you find colony stimulating factor 3 receptor in CNL or atypical CML. And conclusion from these studies at the bottom of the slide is that the majority of patients with CNL have that, and not many with atypical CML. But there is a study underway, and you may be familiar with that, with ruxolitinib, for patients with CNL or typical CML, regardless of the mutation profile. After the fact, the mutation profile will be tested. And please, if you have such a rare patient, try to find a site for this to be tested further. We heard yesterday about mastocytosis, and the KIT is driving mutation behind that. Obviously, there are many other mutations that can impact the aggressiveness of the disease or response to current therapy, and we heard very nice summary on midostaurin, which was finally one of the KIT inhibitors that was approved after testing nilotinib and dasatinib. But you may be also aware that there are two other drugs that are being developed as a super-specific KIT D816V mutations inhibitors. Blueprint Medicine and Deciphera are the two companies that are leading the efforts. These are phase 1-2 studies that are accruing patients with the possibility of improving what we have seen with midostaurin so far. And the last disease, and perhaps most exciting, is 8p11 MPN. This is really rare. FGFR, this is one under the myeloid lymphoid neoplasms. All right, anybody had a patient like that? Anybody? Yes? Yes? Anybody else? I had few. These are rare, okay? But these are people that have very bad outcome. This is the summary. There are this is usually discovered, as the title says, by 8p11 translocation. These are the list of those that would activate the FGFR. And it is therefore subgroup in the myeloid lymphoid neoplasms because it can be present as myeloid or lymphoid or overlap of the two in the patients, and survival is usually 1.5 years, 2 years. Not much you can do about it unless you do the transplant. That's a summary on the disease. There is a medication called INCB054828, call it 828, which is a pill. It is actually FGFR inhibitor, and it is being developed for urothelial cancers and other solid tumor cancers where the FGFR is activated for different reasons. But one patient with 8p11 so far was treated on that multi-disease phase 1 study and achieved complete molecular remission within 2 months. And therefore, there is now a study. You don't need much. You need one extraordinary response in an extraordinary rare disease to give you a signal. And there is a study called FIGHT-203, which is, as you see, phase 2 study of 828 for patients with lymphoid myeloid neoplasms that have 8p11. And there are 2 patients already out of a goal of 46. Just the open and accruing patients. This is across the globe, basically, because it's so rare, but it might be so effective. And if you do have a patient, please respond. You can send me an email. We'll engage because this is something like what you say, perhaps Gleevec for CML when Gleevec came around. So it's extraordinarily potent medication based on one case, but one case is good enough for me to treat the second case. So otherwise there is not much really to do. So these are the endpoints, the study up and running, and please let me know if you have a patient. Very important. So where is the field going? I gave this question to a friend of mine, Dr. Vanucchi from Italy, a few months ago, and he sent me this. So I said, oh my goodness, I really love that. So I put courtesy of Dr. Vanucchi at the bottom, but this is... We are going in multiple different directions, okay? It's fun because we don't really know. There is no straightforward plan. It's exploration of multiple different possibilities, and that's the whole point here, not to be subject to certain prerequisites or certain path. Let's open our mind and explore possibilities for our patients to benefit from new medications. So with that, I thank you very much for your attention.